Again, we are here with you this week. The topic of the webinar is hernia and the latest management. Of course, we'll talk about hernia, and I've got for that Dr. Snigdhendu Chand. Dr. Chand is a senior consultant GI surgeon with Medica Kolkata. He operates in Kolkata, he operates in Tinsukia, in many places on behalf of Medica, and is very well known surgeon. When I ask him normally how many surgery you have today, he says 10, 11, 12. And after that, he's fresh. You will be hearing him. You will not feel that he has just finished 9 surgeries and has come for presentation. In fact, 3 o'clock in the afternoon, he tried to ditch me by saying that, boss, I've got 8 operations already lined up. Can I skip? I said, nothing. If you skip, you're going to get beaten. And so he just prepared quickly his presentation, and he's here with us. But there's a surprise entry today. Today I have with me Dr. Aviral Roy. The reason why he's here, he's a medicine specialist and a senior consultant in critical care. Suddenly our numbers of COVID positive has gone up. We have so many patients who are turning to be COVID positive. Not only patients, even our doctors are turning positive. Many of them are on quarantine, though this time the quarantine is very short. Our positivity has gone up to the roof. And if any of you are still spared, it's not very long before it catches up unless you are careful. So as a surprise entry, we wanted Dr. Aviral Roy to update us, where are we with this current corona wave? So with this, over to Dr. Aviral Roy.
Hello everyone, Namaskar. Hi, Dr. Roy speaking. I promise I will not take long, not more than 3 to 4 minutes. So as Dr. Roy rightly said, we are all, I'm sure as many of you are aware, we are noticing a sudden spike in the number of COVID cases. To cut long story short, I'm sure all of you are aware that Omicron was the last variant that has affected us. This continues to be Omicron, but this appears to be one of the sub-variants of Omicron. During the previous wave, we mainly underwent Omicron BA2 variant. This appears to be BA3 or BA4. But the good news is it continues to appear to be a very, very mild infection. Overall, as long as you have taken your vaccines and as long as you do not have any comorbid conditions. For patients who continue to have comorbid conditions and who are not vaccinated, COVID continues to be a relatively severe disease with a more than 10% chance of needing hospitalization for either oxygen or ventilation therapy. This being said, we have come a long way from from 1 to 2 years ago when we did not have much medication available. We now have multiple oral drugs along with IV medicines for controlling coronavirus and ensuring rapid recovery. As always, prevention is better than cure. Please be careful when you do go outside. Please wear masks. I was just looking at the most recent numbers of COVID-19 in West Bengal. In West Bengal, as of yesterday, because today's numbers will be updated at 8 p.m. at night, there were 660 cases of COVID-19 in Calcutta itself, and the day before that was 750, of which 50% of which are in Calcutta itself. More concerning is the case positivity rate, which is the number of tests per 100 that are positive for COVID, has gone up from 0.3% about 1 month ago to roughly 7% now, and it is continuing to go up. We expect this number to hit at least 20 to 25% in the next week to 10 days. More importantly, a lot of patients, I'm sure you're getting the rapid antigen test done and are not necessarily reporting. So the actual number is probably understated by a factor of 10, which means if we are seeing 700 cases, the actual caseload is probably close to 6 to 7,000. Please continue to mask. Please continue to wash your hands. Please continue to do social distancing. If you have a patient who is sick at home or has COVID, please remember that to take care of yourselves, to quarantine the patient. We continue to quarantine for 7 days. Please make sure you see a doctor so that symptoms are recognized early, treatment is started early, and recovery can be made as soon as possible. With that, I'll complete my short 5 minutes. Basically, in do not worry, mild disease. See a doctor quickly so that we can start treatment quickly, and stay safe. Prevention is better than cure. Thank you so much, Dr. Roy. Back to you. Dr. Roy, you're muted currently.
Aviral, what is the disease profile you are experiencing in the OPD? What do they present with?
The most common symptoms, as with this wave, continue to be the one with the previous wave. A little bit of a headache. They get upper respiratory symptoms, so they start sneezing, running nose. It starts with a low grade fever and a mild cough. Luckily, this time we're not seeing too many patients progress into the pneumonia part of disease. That is when they start having cough with expectoration, sputum production, and with dropping oxygen levels. But yes, we have a few patients who are very sick, who are highly diabetic, on chemotherapy or immunosuppressants. Those are still requiring BiPAP or mechanical ventilation. Nobody in mechanical ventilation, but they are needing BiPAP or high flow oxygen to help control their symptoms.
So you are saying that those who are immunocompromised and those who are elderly and comorbidity, they need to worry about. Is that true?
I wouldn't say worry. They should be concerned if they come early to us. Recognition of disease is important. If they come early to us, there are a lot of oral drugs we can give them now, like molnupiravir and others, which can control the symptoms very quick and prevent them from going forward. What we are seeing is people who ignored the first 4 5 days of the symptoms and then turned up. We don't have much options available there. Then we have to go back to steroids. The early drugs we can give don't work this late.
Fine. So what Dr. Roy has said, and which we are seeing, suddenly we are overwhelmed with the news that so and so have got COVID, so and so got COVID. But the 99% of them are not doing a standard COVID RT-PCR or CT-LAT. They are doing the RAT test at home. And RAT negative is not guarantee I don't have a COVID, but a positive one is sure that you have COVID. So the moment RAT positive turns out to be, they take precautions. And when they're negative, they keep on roaming around and infecting others, not knowing that they're truly positive. So the number suddenly is soaring. It's like a tsunami hitting us. Though the disease profile is very poor, the patients are not really falling sick. The burden on the hospital is not very high. And we don't worry about it as much as we did 2 years back. Today, if somebody is positive but has no symptom, we still operate on them. But if they are positive and symptomatic, we don't operate on them. So like what we do for common cough and cold, if somebody has a common cough and cold, we don't operate on them. But if they have a virus or influenza, but there's no symptom, we still operate on them. And the people are coming back to the work with double mask and all that because we are worried about workforce falling sick. Stay home, stay healthy, observe precaution, avoid crowded place. Time has come for you for 1 week, avoid crowded place because that's where the exchanges are. Otherwise, nothing to worry, nothing to fear. Live well and happily. With this, we move on. Thanks, Dr. Aviral Roy. Thank you very much for your viewpoint and coming in at a last minute notice because we felt that we need to share with you. And with this, we move on to Dr. Chand with this topic, hernia and its management. Dr. Chand, over to you.
Sir, good evening. It's again indeed an honor and pleasure to express our talk with all our esteemed viewers. My greetings, my warm greetings from Medica Super Speciality Hospital to all our esteemed viewers. And, sir, at the beginning you just mentioned one thing, Chand must have got tired and all those things. But yes, sir, once I see you, once I get the air of you, once I listen your words, I get all the energy in this world. And again, I can go back and give me another 10 patients and I can operate for the hospital. I'm so happy. And sir, I'm very happy you have selected a fantastic topic, sir. It's a hernia. It's a very common topic. And it's a very old disease also. So we can share with our esteemed viewers and we can share what are the latest modalities of treatment, what we are doing here, and all the latest modalities of treatment we are doing in our hospital. And I would like to share this platform with all of our esteemed viewers. And as far as given me a topic about hernia, sir, I would like if you ask me a few questions and I can answer all my viewers, I'd be more glad for that. I cannot hear you, sir.
IT, start presenting.
Yes, sir.
No, from the beginning. First. From the first. Oh. Yes. Start. Yeah. Recent advances in hernia. This is my hospital, Medica Super Speciality Hospital. I am Dr. Snigdhendu Chand. And the right side, you can see Dr. Gaurang Charan Naik. He's my brother, my mentor. We both work together in tandem. And we both are surgeons in Medica Super Speciality Hospital. Next, please. Yeah. Definition, hernia. Hernia is a protrusion. It's an abnormal protrusion of an organ through its containing wall. Next. And the composition of hernia, it has got a sac, it has got a mouth, it has got a body, it has got a neck, and it is the bowel and everything they enter through this containing sac. Now, composition of a hernia. Hernia means it's a defect and it has got many layers. These are our anatomical part. I'll just skip very quickly. So hernia contents, it may be omentum, means the fat and all, it may be intestine, and it's a part of intestine like that. So we go ahead with it like that. So these are all the contents of the various contents of the contents inside the hernia sac. Next. Etiology means why it happens. Hernia occurs at the site of weakness in the wall. Suppose any wall is there. If there is a weakness, it happens. This weakness may be, it's a normal weakness. It's a physiological weakness related to anatomical causes, and maybe congenital abnormality are there. And some hernias are acquired, maybe traumatic, and maybe after due to some diseases. The varieties, hernia may be reducible, irreducible. Reducible means it can come in and go in. Irreducible, it comes in, but it cannot go back. Next. So there are other varieties of hernia incarcerated, and hernia can get obstructed, hernia can get strangulated. Strangulated one is a dangerous type of hernia where the arterial blood supply is compromised and bowel become gangrenous. You can see there are three pictures. The left side, you can see it's an irreducible hernia. The middle one is a reducible hernia which can go in and come back, and strangulated it. It has gone inside and it is unable to come back, and the vascularity compromised. The blue line is that part of the bowel is gangrenous. It's a dangerous one. Now classification. See, external hernias, which you can see in the body outside. See, epigastric hernia just below our chest wall, then umbilical hernia at the right flank, syndromal hernia, then incisional hernia. You can see a scar over the scar, previously operated scar, if there is a swelling, and that is called incisional hernia. Other types of hernia, external hernia, you can see inguinal hernia, which happens in our, the junction between the thigh and the abdomen, that is the inguinal region. There we have got inguinal hernia, femoral hernia, and at the umbilicus we have got umbilical hernia. And again, previously I said incisional. If there is an incision, means any scar or any operative area, and if there is a swelling in that, that is called incisional hernia. External hernia, the many names, pigelian, occipital, lumbar. Next. Yeah, internal hernias, the hernias which are not visible, the hernia inside the abdominal wall, inside our abdomen, they are called diaphragmatic hernia. They're esophageal and paraesophageal, like that. Yes, signs and symptoms, when you cough, the size increases, it can reduce, it cannot reduce, and hernia is usually diagnosed, it's a surgeon's diagnosis, but we take help of other modalities of investigation, CT scan, ultrasonography, like that. Management, we manage hernia like herniotomy. Young children, we do herniotomy. then herniorrhaphy, then we do hernioplasty, that means we repair the hernia and we put a prosthetic mesh, that is called hernioplasty. Next. Now this is a inguinal hernia, you can see those deep dark blue, deep color, grayish color thing, see how it is entering into the defect and it is getting twisted, so this is called inguinal hernia into our scrotum through the inguinal hernia. Next. And this is the important factor. Why hernia happens? That is very important. Whenever a patient comes to me in OPD, then I ask whether he's having chronic cough, constipation, straining at maturation, like if he has got those teeth enlarged or not, multiple pregnancies, and a patient's lifestyle is very important, his occupation is very important, and associated with other comorbid factors. One of them important is ascites, means fluid in the abdomen, which increases the intra-abdominal pressure and it causes a hernia. Again, signs and symptoms, there will be a bulge when you cough, the size will increase, when you stand, it will increase, when you lie down, it will go back. So these are the signs and symptoms. Two types of direct, indirect, these are all medical terminology. I like to skip them. Next. Complication. This slide is very important. What are the complications? There are three complications, mainly irreducible. When it comes, it doesn't go back. Obstruction, which urgent surgical repair is required, and strangulation, which is the most dangerous one. Emergency operation is required in strangulation, because in strangulation, the bowel gets strangulated and it becomes gangrenous, then it becomes life-threatening. That is the deadliest complication of any hernia. Yes, management. I previously said herniatomy, herniorrhaphy, these are anatomical problems. They are managed by surgery, and the first hernia operation started in the world was in Toronto, that is in 1884 by Bassini. Still we follow that type of repair, but yes, with the advent of many newer technology and many newer methods, we are doing hernia in a latest technology. Yes, hernia, if you want to avoid surgery in few patients where surgery is contraindication, you can see the picture, trust can be used. Yes, now it is that, now the latest thing, that is the laparoscopic repair. Yes, we are doing laparoscopic repair, all type of laparoscopic. This is TEP, that is total extraperitoneal, right? We don't go into the abdomen. Between the abdomen and the skin layer, we enter and we repair the hernia. We put a mesh laparoscopically and patient is home within 24 hours. Next. Yes, this is another type of laparoscopic hernia. This is called total abdominal pre-peritoneal, trans-abdominal pre-peritoneal. I mean, we enter inside the abdomen, then the defect is repaired. We open the hernia sac, the defect is repaired. Then we put a mesh, then we close it, and it's also a latest modality of treatment. Yes, iconoplasty. This is today's picture. This was our second operation today in my hospital. You can see how the light is there. She was having a big umbilical hernia. We have entered inside, and after reducing the thing, you can see how the light is getting transferred. The central part, that is the hernia. Next, please. Yes, you see the content. These are today's picture taken from the OT, and how you can see how the bowels and this yellow fat, and that above is the defect where it has entered. Next, please. Now everything has been released, and you can see how it is being sutured. The defect is being sutured from the inside of the abdomen. Next. Now see, finally you see how we have put a mesh. You can see some steel, small things. They are with a gun. They are fixed. They are called tackers, so that the mesh is hold and to the parietes, and within a month or so, they will get fibrosis and they become an artificial barrier type inside the abdomen, and the hernia defect is cured. Yes, femoral hernia, the many types of hernia. Next, please. Surgical repair. Any hernia, they are anatomical problem. They repair with surgery. Next, please. Yes, umbilical hernia. See, you can see the picture. It's an umbilical hernia, how the umbilical is swollen. This mainly happens in a children because of incomplete closure of the umbilical orifice. Why? That place is the connection between the mother and the child. So that is the most weakest part in our abdomen, and the majority of that weakness that closes in the first year of life. But yes, if it persists and it doesn't disappear after 3 years of life, then it is the umbilical hernia. then we can say it's a congenital. Even umbilical hernia occurs in elderly patient because of many causes. Paraumbilical hernia means the hernia above the umbilicus or side of the umbilicus or around the umbilicus is called paraumbilical hernia. Yes, paraumbilical hernia. Why? You can see the underlying part. It's the neck of the sac is usually narrow, and therefore there is a high risk of strangulation. So whenever if the neck is narrow, that hernia is very dangerous than if the neck is bigger, because the small thing, if it enters, the bowel enters, but it cannot come back, then it gets strangulated. You can see various pictures, how the hernia is formed: paraumbilical, acquired umbilical, congenital, and normal umbilicus. Epigastric hernia, yes. In the picture I have shown epigastric hernia just below your chest in the central abdomen. You can see there is a swelling, and like a patient comes to us, this is after food, I have a bloating sensation, I have a pain. This is a very atypical hernia where if you cough or if you strain, it doesn't increase the cyst size, and that is the hernia which doesn't have any sac. Incisional hernia means, you see, this is very important because many of the patients who undergoes major operation in their lifetime over the abdomen, what happens? Why it happens? Mainly age, wound. After that operation, if the wound healing was poor in the older patient, obese patient who are quite fat, and if that operative site the previous operation, if there was a wound infection in that area or there was a blood collection in that area, and after operation, if he has coughed, he has strained, or he has constipated, then this incisional hernia happens. And like if you give after operation, if a patient requires steroids, and if the technique was a suturing technique, then also this happens, this hernia. These are called incisional hernia, and we get majority of elderly patients with incisional hernia from majority of the elderly patients. Yes, signs and symptoms. Again, the same thing. Any hernia, if you cough, if you strain, it will swell, and it usually happens 4 to 5 years after the operation. Sometimes it happens also earlier, and the most important thing is, if it happens, then you have to see a surgeon, and the treatment. I mean, surgery is the most important treatment for this type of hernia. Yes, signs and again next. Riches hernia. This is a type of hernia where a part of a bowel is obstructed, but it is not. It is entered. It is not obstructed, but only a part of it has entered. Yes, diaphragmatic hernia. These are the hernia inside our body which we cannot see. There are two types. The sliding hernia next, and there are some other type of hernias. There are various types: Spigelian hernia, Litus hernia. It depends with what type of content is there and where it is placed accordingly. Obturator hernia, yes, lumbar hernia. Now these are the picture of the hernias which are inside our body. These are stomach and the esophagus. How the hernias are happening, you can see. Yes, this is Gaurang on my right side. I'm Snigdhendu on the left side. Thank you everybody. I'm quick with my presentation.
Right. Thank you, Dr. Chand. It was a very, very medical presentation. Now I have to really convert into a language which my listeners will understand. So hernia, what Dr. Chand has said, is the tissues inside your body when the wall, a soft wall, which becomes weak at a point, the inside tissues come out of that weakness is hernia. Now, so Dr. Chand, between the male and you must be repairing so many hernias. Tell me which is more common, hernia in a female or male?
Hernia, there is a slight difference, like book says 55% and 45%. There are various type of hernia, like inguinal hernia, they mainly happens in males, and like femoral hernia, it happens in female, and incisional hernia, mainly incisional hernia happens in female, because nowadays most of the female, they are going for cesarean section. So that is a common operation they are having, and after cesarean section they come and female abdomen are quite flabby and after incision. So somehow I'd say in certain hernias, male they have the highest rate, and in certain areas, females have got the highest.
But so distribution is more or less equal.
Yes,
So
sir.
men have mostly the hernia inguinal. Inguinal hernia is where the abdomen meets your thighs. That's the area which is known as inguinal, and that is where the weakness happens in a muscle ball, and the intestine comes out of that sac into the either your scrotum or into a skin around it. So inguinal hernia is the most common hernia in men. Is that true? Can I make a statement?
Yes, it is true. Immunology.
Now, earlier we used to cut open the skin, then push the content back into the stomach and repair it with a mesh. Now you are saying that you do it with the laparoscopically. So can you explain that? What is the advantage of laparoscopic over the direct incision?
Sir, very nice question, sir. I appreciate. Like I will give a small example. Suppose you imagine this is a bucket. उसमें फूटा हो गया है. There is a hole. So if you repair that hole from inside of the bucket, that is laparoscopic treatment. And if you repair the hole from the outside, that is called traditional open surgery. So, and I would like to say, hernia surgery is one of the first surgery which was invented by our surgeons. It was in 1884. The first surgery started by Bassini in Toronto. So just imagine how long back they have made this operation successful. Still, we follow some steps of them till today. So the difference between open and laparoscopic surgery is, in nowadays, people want less pain. People want to go back to their work very quickly. If we cut, then there is a chance of infection, and pain will be more because the body, when it bends, you only bend there. It's like a book. If you fold a book, it's the center. So your body at that is the center. So whenever you bend, whenever do any movement, so you get hurt there. So definitely after open surgery, discomfort will be more. But in laparoscopic surgery, what happens? The pain will be less. The access is minimal, and patient can go back home very quickly. Like in our hospital, we discharge the patient in 24 hours time. So the technique is same, like small things I just explained. It's closing from inside and closing for outside. But yes, we also select some patient. I mean, patient selection is very important. It's not always ki if they come ki yes, laparoscopy can be done. Yes, there are certain contraindications not to go for laparoscopic surgery. And there are also some contraindications. If you are a laparoscopic surgeon, there are also contraindications for open surgery. But yes, laparoscopic surgery has got much more advantage than open surgery. But it needs real technical skills, because I would like to say it has taken me years to make mastery in this surgery, because it's quite challenging also. It's very difficult also, sir. The learning curve is also very steep, sir.
Thank you, Dr. Chand. Dr. Chand, you said that in women, one of the hernias are incisional hernia. So, which happens when they have abdominal surgery, maybe open gallbladder or appendicectomy or the cesarean section. Now, this incisional hernia, why is it common in women and how to prevent it?
It is common over women because women in their lifetime, we notice, suppose a woman of a middle age or a woman touching around 50, by that time, when we ask any woman, whenever they come to my OPD, I ask them, have you gone any abdominal surgery? They go, yes, yes, sir, yes, sir. I'm like, what? First they will start either cesarean section, then hysterectomy. Most of the women at the middle age, they go through hysterectomy. So these are the two most common surgeries with most of the female cases. And there are, yes, other surgeries. Right now, today the laparoscopic surgery has come for last 30 years. Before that, what happened? There was no laparoscopic surgery. For any surgical intervention, we had to cut the abdomen and we have to go inside, we have to do the surgery. So what happens? Whenever you cut the abdomen and you go inside, whenever you repair, the most important thing, why the incisional hernia happens? Because whenever a patient comes to our OPD And when we take a history of incisional hernia, I asked my patient, at what was the sequence of event it has happened in that admission when you had a surgery. Yes, there may be an infection of that area which has made that area very weak. And maybe after operation, she must have constipated, she must have chronic cough, she must be having. And since the female, their childbearing mother, what happens? The size of the abdomen increases. So these muscles, they become weaker, they split. And the female, when they're obese, if they become obese, this muscle again gets splitted. So these all things, what it makes, the tautness of the abdominal wall vanishes, this abdominal wall becomes weak. And over that, if a suture line, if that suture line was infected or having any other comorbid factors and all those things, that makes that line weaker, and continuously straining, coughing, intra-abdominal pressure is increased. So there is a bulge, and gradually it grows in size. And whenever they come to us, they may be having a big swelling, and maybe these contents are going in, they're having discomfort. I cannot eat, I am constipating, I'm having pain, dragging sensation of pain. So these are the main thing which happens in a incisional hernia. Definitely, yes, in females we see a bit more, but it also happens in male. Whoever has undergone any operation, there is a chance, there is a probability they can have an incisional hernia.
So, what are the ways of preventing it after, suppose somebody had a open abdominal surgery. Now he or she has it. So what are the ways of preventing incisional hernia in future?
Yes. So again, a very good question, sir. So after any surgery, that when we close the abdomen, after finishing the surgery, we have to close the abdomen. When we close the abdomen, the selection of suture is very important. What material you are using, what quality you are using, and the sterility of your OT operation theater is very important. You have to see how your what is the quality of your sterility, and infection control should be very high, supreme. No infection should happen over there. And second thing, the skill of the surgeon is also important, because whenever there is this type of hernia, there is a question mark over surgical skill also comes to the point. And the third thing is, after this type of operation, bigger operation, we ask the patient not to constipate, no weight lifting, no coughing, no straining, maybe to 4 to 5 months. I advise the patient to wear abdominal belt or abdominal corset 24 hours except sleeping, so that what happens, the tissue which has been repaired, we have given stitches, but body will take its own time, tissue will take its own time, and they will heal, and they will get back the tensile strength. But yes, to get back the tensile strength after the abdomen is closed, 80% it happens at the time of 6 months. But 6 months is a very long time, sir. And patient, what happens, they become lax. They don't, yes, it has happened. They can do anything. And they're constipating, their intra-abdominal pressure increases. So that becomes weaker. So most important thing is, they have to follow certain advices after operation to protect the abdomen. Like I tell my patient, you just imagine you are having a baby inside. Oh, of course, female patients, they understand. Male patients, they laugh at me. Sir, what are you telling? I'm like, yes, if you imagine you are having a baby, you are protecting your tummy always, nothing will happen. The recurrence rate, definitely in today's era, and with today's modern treatment, modern sutures, improved surgical skills, and improved sterility, the standardized hospitals, and patient choosing good hospitals. So with that, this type of hernia, definitely the recurrence chances will come down.
Okay, Chand, I have last question. One that I have been told, in fact, I've seen it, that many times incisional hernia get repaired by a surgeon, and again after some time it reoccurs. It happens again. Why? Why does it happen, and what is the best way of preventing?
Right, sir. Yes, very tricky question. It happens because किसी का सिला हुआ शर्ट को खोल के अगर आप उसको दोबारा सिलेंगे तो बहुत डिफिकल्ट होता है. If you are given a virgin cloth, you can stitch it nicely. So yes, when this type of hernia comes, our pulse rate also increases. But yes, to prepare this type of patients, when a patient comes with this, suppose somebody is operated, a hernia has happened, or somebody has been operated twice. This type of patient, I got a patient 6 months back who was operated, sir, 5 times. She was refused by big hospitals in our city, but fortunately, we got her. It was a challenging case. She is from Jamshedpur, and it was a really challenging case. She was 108 kilos, sir, with all comorbid factors. So at that time, workup is very important. I do CT scan. I speak with my radiologist, and I go to the console along with Dr. Naik. We sit, we see the entire video. We discuss with our radiologist, picture what should be our plan, and then why it comes back. If that defect, that sac, there is a sac, kuta. If that defect is not repaired properly, there will be a weakness. Again, it will push down. Again, it will pop up. So the defect has to be closed properly. The sac has to be identified properly. And then in today's era, we are having mesh also. What is a mesh? It is a prosthesis. जाल बिठाते हैं, जैसे हम छत करते हैं, नेट बिठाते हैं, सीमेंट डाल देते हैं, तो स्ट्रॉन्ग बन जाता है. So this net, when we give, in this net, the muscles and the tissues, they grow inside, and over the time, they become an artificial barrier. So putting the mesh and giving rest to that mesh is very important. Like a mesh is placed like this. If you cough, it will, the intraabdominal pressure will increase, muscles, this mesh will go like this. So there may be a defect in the mesh, gradually intraabdominal pressure increases, and the hernia can come back. And inside our abdomen, the interesting part is our intestine. जिंदगी भर पेट के अंदर में बंद रहते हैं, जेल बंदी. They also want to come out and see the world. So hernia is, it's an abnormal protrusion of the part of a viscus or whole of the viscus through its containing cavity. आपने बंद करके रखा. So whenever they will see कि अरे दीवार में weak है, let us go inside. Let us go inside. So they will go. And yes, if the defect, suppose the defect is bigger, every day, suppose imagine a goat. एक boundary है, छोटा सा hole है, every day that goat is putting his head and coming out, coming out, coming in, coming out. But if the hole is bigger, the head can go in and come out easily. But if it's small, it's going every day. Suddenly one day it goes in and it cannot come back. So what happened? Strangulation. Strangulation is the deadliest complication of hernia, sir. So if it happens, immediate, you have to rush to the hospital. And yes, at the dead of the night, mid of the night also, we have to operate, sir, because that is a life-saving surgery. So I always advise my patient, they tell, sir, छोटा सा hernia है, it is not giving any problem. मतलब छोटा सा है पर बहुत ही बेकार सा है. बड़ा होता तो मैं भी खुश रहता. So if the hernia is small, so red flag is moving in front of you. I'll tell all my viewers.
Dr. Chand, last question of the day. That you said strangulation. What are the signs and symptoms of strangulation?
Yes. Strangulation, first of all, there will be severe pain because something is obstructed. Strangulation means you have strangulated, uska gala daba diya. So it has entered, now it is unable to come back. If it is unable to come back, the most important thing is our blood supply, artery supplies, through vein it comes back. So first imagine this is a hole, this is a sac. So this vessel, this bowel has entered, now it has got strangulated, dab gaya hai. So venous blood return are superficial outside. First there will be venous congestion. The returning blood will stop first. Then there will be edema. If it can't come, it will swell. More edema, more strangulation. Then what happens? The arterial supply, which is supplying that part, if it's strangulate mode, is unable to supply. So total cutoff of blood vessels. So if the blood vessel supply is cut off, so this part which has entered, it will become gangrenous. And gangrenous of a bowel is very dangerous because it will become peritonitis. Patient will have severe pain. You can see, suppose if it is umbilical region, or groin region, redness will be there, tenderness will be there, swelling will be there. He will tell the first thing, sir, it was going every day, now it is not going back, and I am having severe pain. First of all, the pain will be in that area only, but gradually, with more strangulation, the pain will dissipate. You will have pain throughout the abdomen. Then the signs of sepsis occurs. The patient will be dehydrated, patient will be toxic, and if anybody sees the real strangulated hernia patient who are in sepsis, it's a nightmare, sir. It's a nightmare.
Thank you. Thank you. So all of you will agree that Dr. Chand has very well defined what hernia is. And he also has said that it can be handled very easily. Don't allow it to strangulate. Don't allow part of your tissue to suffer unnecessarily. And today with the laparoscopic surgery, it can be done and patient can be discharged on the same day or next day morning. With this, we come to the end of webinar. Let's thank Dr. Aviral Roy for giving us overview of the so-called fourth wave in our mind, and to Dr. Chand for presenting it so beautifully. Thanks to Rotary Club of Calcutta, Vienna, and Bengal Chamber of Commerce and Industries for associating with us. Please join us again next week. We'll come up with a very relevant topic for you to stay healthy. Namaskar. Good night.
Thank you. Good night.